Okay, good afternoon, everybody. Welcome to our next ASH review. This is a review on cellular therapies. And we have, I think, two exciting presentations for you this afternoon. The first is going to be with Dr. Isufi. Dr. Isufi is Associate Professor in the Department of Medicine and Hematology in the Yale Cancer Center, and the director of our cell therapy research team and our clinical CAR T program. And she's going to talk to you about some advances in cell therapy at the latest ASH meeting. So, Dr. Isufi, take it away.
Thank you, Stuart. I'm going to share my screen.
First, before you start, can I just remind everybody, if you'd like to submit questions, there will be a question and answer period, possibly between the presentations and at the end, but you can submit questions through the chat or Q&A during the talk, and we'll possibly answer them during the talks or at the end. Okay.
Thanks. So welcome everyone. I'll take the first half of the session just to present some of the ASH data on cell therapies. And I know this was talked about at the myeloma review as well, but today I'll focus particularly on non-Hodgkin lymphomas and some also exciting data on ALL. These are my disclosures. So the first presentation, the first abstract that I wanted to present is abstract 655 that's looking at lysocell, lisocabtagene maraleucel, and this is a cellular therapy product that is different from the prior ones on the market because it has a defined CD4 to CD8 ratio. And this has already been approved in the third-line setting, and more recently also in the second-line setting for diffuse large B-cell lymphoma. So here they presented their primary analysis of the randomized phase 3 transform study, where lysocell was compared to standard of care with salvage chemotherapy alone. So patients had a good performance status. The ones that were randomized to the standard of care arm who had relapsed were randomized to receive 3 cycles of chemoimmunotherapy. These were high-risk patients. They were patients who were either primary refractory to their first line or patients who had relapsed within 12 months of their initial therapy. So they took this highest risk group to compare it to stem cell transplant. And so the patients who received salvage chemotherapy and achieved either a complete or a good partial response proceeded to high-dose chemotherapy and autologous stem cell rescue, typically with a beam regimen. And then the other arm was randomized to receive lysocell, and so they underwent lymphodepletion with fludarabine and cyclophosphamide. And they were allowed to get some bridging if their disease was rapidly progressing. Importantly, in this trial, crossover was allowed for patients who received standard of care and were not deemed to be good candidates for autologous stem cell transplant for multiple reasons, so they crossed over. And the primary endpoint was event-free survival, and then they looked at complete response rates, progression-free, and overall survival. They do have now a 17.5-month follow-up, and that's important because we know that the majority of these patients with primary refractory or early relapse disease will again relapse typically within the first year of salvage. So with that median follow-up, you can see here there was a significant improvement in the event-free survival, where the median event-free survival was actually not reached compared to a median event-free survival of only 2.4 months in the standard of care arm with stem cell transplant, with a hazard ratio of 0.35. And this was, for a cell therapy trial, a relatively large trial with about 184 patients, 92 on each arm. So you can see here that for their secondary endpoints, there is also statistically significant complete response rate of 68% compared to 40% in the standard of care arm, and an improvement in progression-free survival that was not reached for the cell therapy group versus only 6.2 months in the standard of care arm for patients who received chemotherapy and transplant. And importantly, despite 67% of patients crossing over from the transplant arm, the chemotherapy arm, to receive liso-cel, there still seemed to be a trend favoring overall survival in patients who received liso-cel, where overall survival was not reached versus about 30 months in the standard of care arm. So this primary analysis with almost 2 years of follow-up confirmed the significant clinical benefit of liso-cel over the standard of care. And given these very meaningful improvements in complete response rates, event-free and progression-free survival, this and a trend towards overall survival, this has now been approved and is considered the standard of care in the second line for patients with primary refractory or early relapsed lymphoma. And there is another product on the market, but this was the one that had the update at ASH. The next one that I was also interested in is abstract 154, where they looked at really aggressive lymphomas that are high grade with MYC and BCL2 plus or minus BCL6 rearrangements. So the so-called double or triple hit lymphomas, and also double expressor lymphomas with dual overexpression of MYC and BCL2. And we know that those have very inferior responses to frontline and later lines of chemotherapy and have very poor outcomes with stem cell transplantation. There have already been some presentations in terms of the role of CAR-T for this patient population, which has led to similar overall response rates. However, until this abstract, there had not been any data or update on the duration of response for these high-risk groups. And so this multi-center retrospective analysis evaluated survival outcomes with CAR-T, and also what happened to patients with double-hit lymphoma or dual overexpressor who progressed after CAR-T. And there was a large group of patients. They looked at 408, 80 of which had double hit and 328 non-double hit. Some of them received axi-cel, some tisa-cel, and a minority received liso-cel. And the clinical characteristics were similar between the double hit and the non-double hit group. So the median follow-up was also about 18 months from CAR-T for surviving patients, so relatively long follow-up. And what they saw actually was that patients did very well, whether they had double hit or dual overexpressor lymphoma compared to other subtypes of lymphoma in terms of their progression-free survival. Overall response rates were no different, not statistically significant, in the order of 65 to 70%. Complete response rates also about 50%, which is what we expect with run-of-the-mill diffuse large B-cell lymphoma. And the median overall survival was not reached actually for the double hit group versus 21 months in the non-double hit, and not statistically significant. However, importantly, patients with double hit lymphoma who progressed after CAR-T had a very poor outcome with overall survival that was very short, only in the order of 2.7 months. So this is a group of patients that, if they progress after CAR T, we really do need better salvage strategies for. So this was the largest analysis, basically, that provided some update as to what happens with these patients with double hit or dual overexpressor lymphomas. So those patients should be encouraged to participate in CAR T trials and should be considered to receive it as part of standard of care without fear that they're not going to respond as well as the regular DLBCLs. So what about patients who progress after CD19-directed CAR T-cell therapy? This is a very challenging group of patients. As you know, they typically die within 3 months of progressing after CAR T. And so this was a study from Stanford that looked at CD22-directed CAR T in patients who had previously received CD19-directed CAR T-cell therapy. This was initially published in Blood, where they treated 3 patients who had all high-risk features with 5 prior lines of therapy, including CAR T. In fact, one of the patients had commercial CAR T targeting CD19, and then also a bispecific CD19 and CD20 CAR T, and had relapsed. And all of those patients achieved a complete remission with a CD22 targeted CAR T. So that led to this moving forward to a larger study with 38 participants up to 84 years old with a good performance status. They were heavily pretreated with 3 to 8 lines of therapy. The median was 4. In fact, about a third of patients did not have a remission to any prior line of therapy. About 20% had a transplant, and they had all had prior CD19 CAR T-cell therapy. And the median time from leukapheresis to the CAR-22 infusion was 18 days, so a bit shorter than what we would typically expect with the commercial products. And some patients did receive bridging. So the median follow-up has not reached the 2-year mark for some of the cohorts, but very importantly, the overall response rate and complete response rates were very high, higher than predicted, 72%, and a CR of 53%, which is similar to what we see with first-line CAR T. And all of the complete responses have actually been very, very durable, with only 1 patient who achieved a CR having relapsed. And you can see there the progression-free survival and overall survival curves on the left look actually very good for a second-line CAR T and compare very favorably to first-line CAR T. As you can see, the majority of the patients experienced grade 1 or 2 cytokine release syndrome and neurologic toxicity associated with immune effector cell therapy or ICANS. Interestingly, what they saw in the higher dose level, which was dose level 2, is that there was a significant number of patients that experienced what is a syndrome that's very much like hemophagocytic lymphohistiocytosis, and it's got a name of its own, of CAR-HLH. It's a syndrome of high ferritin, cytopenias, coagulopathy, and liver abnormalities. And there was just in general more toxicity in dose level 2. So dose level 1 was the one that had the results I showed you. So that's the dose that they're moving forward with. And then 1 patient developed treatment-related MDS and AML without evidence of lymphoma relapse, which again underscores the importance of us following these patients long-term. Another study of interest is actually engineered allogeneic CAR T-cell therapy. All the commercial products are autologous products, and also the one that I just presented, the CD22, was an autologous product. This is an allo gamma delta CAR T cell therapy, and actually it's a first in class. It instead of targeting CD19 like the commercial products, it targets CD20. And it has both adaptive and innate cytotoxic effector function, which complement CAR targeting, potentially enhancing its efficacy and reducing antigen loss. It expresses MHC-independent gamma delta T cell receptors, so the risk of GVHD is low without the need for gene editing, which is more complex and takes longer. So this is the industry's most advanced CAR asset using gamma delta. And they presented the multi-center phase 1 trial for relapsed refractory B-cell lymphoma. Patients had to have CD20 expression on their tumor cells. They had to have received at least 2 prior lines of therapy. And at ASH, they presented the data for their first dose cohorts in a 3x3 dose escalation scheme. And in dose level 3, they did allow patients to be redosed a week later without any additional lymphodepleting chemotherapy. So the median number of therapies was 4, range 2 to 5. They were heavily pretreated. And 4 of the 9 patients who were evaluable had received prior anti-CD19 CAR T cell therapy. It was very well tolerated. There was no reported graft versus host disease, and there were no grade 3 cytokine release syndrome or neurologic toxicity. And this is their preliminary efficacy data. So as you can see, their 6-month complete response rate was in the order of 67%. And for patients in dose level 3, actually a small number of 3 patients, they had a complete response rate of 100%. So this compares very favorably to autologous products, the advantage being that it's an off-the-shelf product, so the turnaround time is extremely short. The cells perhaps are fitter than those obtained from a heavily pretreated patient without much in the way of toxicity. And then more recently, the company opened a dose level 4 cohort. So now they have a larger number of patients. However, they do not have, particularly the higher dose levels of 3 and 4, do not have very short follow-up. And the patients who have been treated so far, a good number of them, if you see here in red, have actually relapsed. And so the durability of responses is still questionable, and it has investors pretty much really worried, about how this product is going to do in the long run. But again, we just need to see what's going to happen to these patients who are getting the higher doses with longer follow-up. And you can see that the patients here highlighted in yellow are patients who all had prior CAR T cell therapy, anti-CD19 CAR T cell therapy, and they all have achieved complete remission, and some of them are still responding to treatment. So I'm not going to spend a lot of time here, but just to shift gears to bring your attention that CAR T cell therapy is also approved for patients with follicular lymphoma in the 3rd-line setting. And this is based on 2 trials, ZUMA-5 with Axicel and Ilara with tisagenlecleucel. So this was the ZUMA-5 update with a 3-year survival. You can see here that the overall response rates and the complete response rates with CAR T cell therapy are very high in the 3rd-line setting in both patients with follicular lymphoma and also in patients with marginal zone lymphoma. And progression-free survival is very good, and overall survival is very good for these patients with relatively long-term follow-up, because in the 3rd-line setting, typically what we would expect from a third-line therapy is a shorter duration of response that is typically less than 2 years and sometimes less than 1 year, depending on the product used. But here you can see that the median PFS for follicular lymphoma was 40 months and was not reached for a marginal zone lymphoma. And then similar data from the ILARA study looking at tisagenlecleucel, so also targeting CD19, but with a different co-stimulatory molecule that is 4-1BB, with over 2 years of follow-up. Patients who achieved complete response, represented here in the top curve, have not reached their median progression-free survival. And the anticipated overall 2-year progression-free survival is about 60%. There was also this additional presentation that compared axi-cel to other third-line standard of care therapies for relapse refractory follicular lymphoma. And this was retrospective in nature, but compared to Scholar 5 study, that does show a substantial improvement with axicabtagene, with a cellular therapy, compared to other third-line therapies. But again, it's not a randomized study, and it's different to, there may be differences in baseline characteristics that do restrict cross-study comparisons. But this is what the progression-free overall survival and time to next treatment look like in blue for patients who had CAR T-cell therapy versus at the bottom in red for patients who would have had other third-line standard of care therapies. And this was published recently in Blood. And then I want to also bring attention to the study published by our very own group, led by Kunal under the mentorship of Scott Huntington, where the cost effectiveness of CAR T-cell therapy was compared in adults with relapse refractory follicular lymphoma. And the cost of CAR T-cell therapy is about $730,000 as opposed to $450,000 for the standard of care, with an ICER of about 80,000 for quality adjusted life years. But I think considering the risks associated with CAR T-cell therapy in terms of cytokine release syndrome and neurologic toxicity, we need to do a better job and have a longer follow-up and randomized comparisons to other lines of therapy, so that we subject these patients to who have the majority of them have long progression-free survival, so that we subject them to minimal toxicity as we can. And particularly now we have a new bispecific antibody approved for follicular lymphoma, which is not a part of these cost effectiveness comparison here, but I think that's also going to play a role, and we need to see how in the long run we're going to best sequence these therapies based on the way of administration, multiple times versus one time, patient preference, toxicities, and cost effectiveness. So I'm going to switch gears now to mantle cell lymphoma. This is abstract 623, which is a phase 1-2 study of a tandem bispecific anti-CD20, anti-CD19. We do have a product that's brexucabtagene that's already approved, but it is very toxic, and there are the hypothesis of this study was that if we use a bispecific tandem product targeting both CD20 and CD19 with expansion with the IL-7 and IL-15, that we might get less exhausted CAR products with even more durable clinical activity. And this product actually is manufactured using Clinimax Prodigy device. It's a fresh infusion, and the manufacturing time is quite short. It's somewhere between 8 and 12 days. So for patients with rapidly progressive mantle cell lymphoma, it's a great product to have that we can infuse rapidly. And you can see here that the manufacturing rate was very high, 100% with its closed system. There were no grade 3 cytokine release syndrome cases, and there was only one patient with grade 3 ICANS. They were patients that had at least 4 lines of therapy. They were all exposed to BTK inhibitors, and you can look at long-term progression-free survival looks excellent. And we already have the diffuse large B-cell lymphoma study, but we're going to go ahead and open this for mantle cell lymphoma at Yale. And then finally, I'm going to switch gears to talk a little bit about T-cell and B-cell leukemia. So this was published in Blood this year. As we know, finding a target for T-cell lymphomas and leukemias has been challenging. CD7 is a very commonly expressed antigen, but it is expressed in the T cells, and there is concern that there's going to be fratricide. The way this is a Chinese group that they actually developed a novel method of CD7 antigen masking that makes the cells fratricide resistant. And this was their initial study was published earlier of these naturally selected CAR T cells without genetic modification. And then abstract 980 looked at 53 patients that had relapse refractory T-cell ALL or T-cell lymphoblastic lymphoma treated with this therapy. You can see they were very heavily pretreated group of patients. About half of them had more than 5% and blasts in their marrow. Some of them had extramedullary disease even, and they had very decent overall end event-free survival in this relapse refractory setting. So the median follow-up is pretty long, 206 days. Some of the data is here. I'm not going to go into it in detail, but suffice it to say that the 18-month overall survival was 75% and event-free survival of 53%. And some patients were bridged to an allogeneic stem cell transplant, but many patients were not. And the ones that achieved CR were able to maintain the CR. So this was highly effective, including in patients with extramedullary involvement or patients who had prior CAR T. And they did identify patients with STIL-TAL1 having a poorer response and early relapses. And when relapses occurred, they did see loss of CD7 expression. Now, the Stephen Grupp group at Penn presented this abstract of CD22 targeted CAR Ts in children and young adults after having relapsed post CD19 CAR T cell therapy for ALL. And they enrolled 19 patients that had the product successfully manufactured. 17 patients were infused. All of them had CD-negative disease that had relapsed post-CAR T. And some of them had received blinatumomab and inotuzumab, and 9 had had a prior transplant, including 3 with multiple prior transplants. The bone marrow blasts pre-infusion were high. And you can see here that the probability of survival for this group of patients getting CD22 therapy is pretty good. The 18-month overall survival, actually they have even longer follow-up for this study, but you can see here that the probability of survival at the 18-month mark is still relatively decent for patients who otherwise, most of them, as you all know, would have very poor outcomes and would succumb to their disease. So now they have almost 30 months of follow-up, and the median relapse-free survival is about 5 months, and overall survival is about 16 months. So there were 2 patients that also were retreated with this for CD22 relapse disease after initial infusion, and one of them went into remission again. So there's a possibility of retreating these patients, and all of that data is here. But I just want to emphasize that we can salvage a portion of patients who fail CD19. You can see here 77% achieve a CR, and including undetectable MRD by flow. They do develop toxicity, and particularly the risk of infections is extremely high, and cytopenias after back-to-back CAR T-cell therapies like this. So they had successful manufacturing, again, with an autologous product, and there were high initial response rates, but there are later recurrences. And I think what's being looked at now is how to combine CD19 and CD22 to decrease the risk of relapse. I'm not gonna, I know we're running out of time, so I'm not gonna spend too much time on this abstract, but it did compare CAR T-cell therapy in both patients who had received blinatumomab and inotuzumab and patients who had not received blina or inotuzumab. And this is in the adult population where they did this propensity score matching analysis. And what they actually found is that the group that received CAR T-cell therapy with axi-cel had much higher complete response rates of 85% versus patients who had other standard of care approaches, also predominantly chemotherapy, of 35%, with a median overall survival that was higher at 16 months versus about 5 months. And this was true in both patients who were treated with blina and inotuzumab before, but also patients who were treatment naive, that both of those groups, we should consider CAR T because patients do respond and may have improved outcomes compared to other standard of care approaches. The relapse phenotype is very important, and it informs our therapeutic decisions. So about 22% of patients will relapse with CD19 positive disease, about 15% with CD19 negative ALL, and about 3% have lineage switch. And the group that has lineage switch actually is the group that has the poorest outcomes, and they have quite poor outcomes even with CAR T-cell therapy. And then post-CAR T, there is even more increasing complexity of the relapse immunophenotype. And the most difficult of all group to deal with is the group that post-CAR T now have both CD19 and CD20 negative ALL, and again, the patients with this lineage switch. So what this is the group from the NCI, Nirali, that published recently and also presented at ASH, that patients who get blinatumomab prior to CAR T-cell therapy and do not achieve a complete response to blinatumomab have very poor outcomes post-CAR T. And that, again, having CD19 dim disease pre-CAR T will influence the post-CAR T-cell relapse phenotype, that a lot of those patients will have CD19 negative disease at the time of relapse, and they will also have very poor outcomes. So it's very important in ALL for us now to really break down the groups and follow these patients, not just with B-cell aplasia, but actually follow them even more closely with MRD by NGS techniques, because some patients may still have some persistent B cells there, but still relapse early, and we really need to move those patients toward clinical trials or doing an urgent allogeneic stem cell transplant. So I think that perhaps we'll leave questions at the end to allow also Dr. Gowda to present. So I'm going to stop sharing.
All right. That was an awful lot of exciting information. There is one question in the Q&A. Dr. Isufi, maybe you can take a look while Dr. Gowda is presenting. Next is Dr. Lohit Gowda. He's assistant professor in the transplant and cell therapy program here at Yale, and he's going to go over some new and exciting transplant results from the ASH meeting.
Hello, everyone, and it's a Friday afternoon. I promise I'll get you guys out for lunch in time. No conflicts of interest. Here are my acknowledgements from the study investigators, the study groups, and different individuals who've shared their slides. The main objective of today's talk is largely clubbed under three main headings. As we all know, allogeneic transplantation has a 70-year track record of cure, but relapses do happen. So I'm going to present you some data about the role of preemptive maintenance post-transplant. One of the Achilles heel of allogeneic transplant has been graft-versus-host disease. Normally, I would present under two headings, acute and chronic graft-versus-host disease. Based on the most recent data that I'm going to present, looks like you might have one drug which is taking care of both of that. So that's a phase 3 study that I'm going to be talking about. And finally, I know it's the last talk of our CME series, but throughout myeloid group discussions, we've learned that there are many novel exciting advances that drugs are coming through. But I'm here to convince you guys that despite those drug advances, allogeneic stem cell transplant is actually is at the forefront, and we anticipate a high number of patients going forward to receive allo transplant because outcomes have gotten significantly better. And I'll bring about some data to support that statement. All right. And the first study that I'm going to be talking to you is a study that was done across from CDFO, which was using IDH2 mutation subgroup, which happens in about 20% of the cases, 20-25% of patients. We all know the drug enasidenib is approved in mutant IDH class 2 types. In that subgroup, those with the relapsed refractory AML, the ORR is about 40%, but the responses do not last long, with the median duration of response about 5.8 months. So the group here actually tried to do a maintenance concept post-transplant, wherein they introduce the drug post-transplant from days 50 to 120 at about 100 milligrams per day. The plan was to give for about 2 years, and each cycle would last for about 28 days. It's a small group study. The total was 15. They included patients that had a transplant in CR1, CR2, and who had MRD positive cases post-allo at CT as well. In this study, the median time to start the drug was 105 days. They allowed various graft, various GVHD, and various transplant preparative conditionings. The median age of the population was about 58 years. And all grade adverse events during the study was reported for the first 2 cycles, whereas for grade 3 or higher for subsequent cycles were reported. In the first 2 cycles, it's usually all of them was included. The methodology used to monitor for IDH2 was a digital droplet PCR. And as has been shown here, if you focus on the right, one of the commonest concerns that we have of using these drugs is cytopenias. The risks of cytopenias, lymphopenia, anemia, and neutropenia was pretty modest, and it's not really significant for those who use the drug in the pre-transplant context. That's a major issue, but those are usually the people that have an abnormal marrow and the disease in association. So I was surprised to see the cytopenias, although existent, wasn't significantly high. And a GI side effect was other common side effect. Interestingly, at least as was presented with the median follow-up of 17 months, the 1 and 2 year progression-free survival was about 100%. Commonly, when we talk about maintenance, we talk about FLT3 inhibitor studies. We're waiting on the full data of the BMT-CTN study that used the FLT3 inhibitor. But I think outside of that, IDH2, where we have targeted agents, is an important subgroup, and I thought this would be of meaningful practical use as we treat our patients. The other maintenance study I'm going to talk about is a phase 1 study. Some of you might be aware that venetoclax has also been integrated in the transplant preparative regimens. This study was published by Garcia and colleagues from Boston. What they're now presenting is when you integrate venetoclax to fludarabine and busulfan, which is a preparative regimen that's commonly used in the transplantation context, they're trying to add the HMA and venetoclax as a maintenance post-transplant. The last decade predominantly has focused on using azacitidine as a maintenance, and there are many interesting reports in that regard. But the combination, as you realize, the doublets and triplets are making forays in the non-transplant context, and I also see this now coming in the post-transplant context. And this is one of those phase 1 study to identify the doses. So they started out with venetoclax 400 milligrams from day 1 to 14. Azacitidine was used at 36 milligrams per meter square on days 1 to 5. A lot of AZA trials in the past have tried different doses, different days, and I think at least in this study, they kind of narrowed it down to a slightly lower dose, which with the hope that perhaps the combination is well tolerated. As was expected, cytopenias were seen. Neutropenia was 95%, thrombocytopenia was 91%. So cleverly, the DLT definition of that study was grade 4 neutropenia, thrombocytopenia greater than 2 weeks. With a median follow-up of 12 months follow-up, regardless of whether the patient got maintenance, the 1-year progression-free survival, OS, NRM, and relapse are reported here. The OS was 70%, PFS was 57%. There was no non-relapse mortality, suggesting it's a safer combination to pursue even in the post-transplant context, but relapse was still of concern, despite using a doublet combination in the post-transplant context. Now, we'll switch gears and talk about GVHD. Now, many of you know that calcineurin-based combination, tacrolimus with methotrexate, has been a standard of care for the last 4 decades. So in order to explore more on how we can optimize and identify the best combination, BMT-CTN 1203 study ran a 3-arm study wherein they checked the conventional arm TAC methotrexate with bortezomib, TAC methotrexate with a chemokine inhibitor versus a post-Cy arm in a phase 2 study. And the winner of that study was the post-Cy arm, which we call the PTCI. This was then taken to a phase 3 study where PTCI, tacrolimus, and mycophenolate was compared against the historical control, which is TAC and methotrexate. The study allowed reduced intensity conditioning for individuals 18 years or older. They had to have controlled disease, and peripheral blood stem cell grafts were chosen. Donors could be 6 out of 6 HLA matched, or 7 to 8 or 6 out of 6 HLA matched donors, or one antigen mismatched unrelated donors were also aligned. The primary endpoint of the study was 1-year GRFS, as has been defined here, even being defined as grade 3 to 4 acute GVHD, chronic GVHD requiring systemic immunosuppression, relapse, progression, or death. And there were a few traditional transplant pertinent and secondary endpoints chosen. Here's just a summary of what happened. There were slightly more men. The median age here was about 66%. Almost half of the people had a performance score less than 90. It had a wide range of hematologic malignancies. And here's a percentage of related, unrelated donors, with unrelated donor being the commonest platform. They did allow different regimens to be chosen, that is BuFlu, FluMal, to go with, which perhaps in modern day are some of the commonest options used. Planned post-transplant maintenance therapies was used in about approximately 25% of the people in the post-Cy arm versus 22% in the non-Cy arm. The study did meet the primary endpoint. The 1-year graft versus host disease relapse-free survival was superior with the post-transplant cyclophosphamide, as has been shown here, with a hazard ratio of 0.64. The rates of grade 3 to 4 acute GVHD was 6.3% versus 14.7%, suggesting post-Cy is able to decrease graft versus host disease. And same with chronic graft versus host disease requiring immunosuppression. The post-Cy arm had about 12.5%, methotrexate arm at 25%, basically halving the risk of chronic GVHD requiring immunosuppression. And importantly, GVHD-free relapse-free survival was almost 62% compared to 45%. Often there's concern that when you use immunodepleting agents, there's the GVL is impacted. As is shown here, it seems to be disentangled, and relapse and progression was not a concern with the application of post-transplant cyclophosphamide compared to TAC methotrexate. Treatment-related mortality, it's 12%. If you all read our books back about 10, 15 years old, treatment-related mortality with transplant used to be about 25, 30%. Now that number has come down significantly, and the overall survival in this arm was about 77%. Of interest to note here is that overall survival at this time point actually didn't change. It was 77% versus 72%, but remember the study endpoint was GRFS. So then people tend to ask, what about the secondary outcomes? Highlighted in purple are the ones that were not significant, and in the dark bright yellow is the ones that are significant. 1 year survival didn't change. 1 year disease-free survival didn't change. TRM did not change statistically. Cumulative incidence of acute GVHD, grades 2 to 4 did not change. But what did change, though, is cumulative incidence of acute GVHD day 100, grades 3 to 4. If you have grade 1 and 2 GVHD, most times it's not of a significant concern. The higher grade GVHD are the one we are concerned about. With the post-SI was 6.3% compared to about 14.7%. Similarly, chronic GVHD at 12 months was 21% compared to 35%. The cell recovery was slightly slower, both for neutrophils and platelets, and as is commonly expected. And the risk of grade 3 infections were not that significantly higher at 12 months. Now was the risk of CMV reactivation. Importantly, immunosuppression-free survival at 1 year was better off, as has been shown here. The other question people ask is about, what's the risk of graft failure, or how does the chimerism play out? As shown here, they have definitions for what's a full chimerism, mixed graft rejections. There was really no significant differences based on that between the two treatment arms. Specifically, people ask that if this is making significant progress in the field of acute and chronic GVHD, does it have any other side effects? Well, the risk of acute and chronic GVHD was significantly lower, but there did come up a concern about some organ failure, and we're looking through the full manuscript to see which particular organs were affected, as it was slightly higher in the post-transplant cyclophosphamide arm compared to the conventional care arm. In summary, the superior GRFS owing to the reduced severe and acute GVHD led to the post-I arm winning in this trial. There was no increase in relapse/progression, which is critical importance to our people. There was slightly delayed hematopoietic recovery. There was more grade 2 GI events in the infection forms, but they were mostly in the first month. Based on the findings, the field is slowly moving towards the option of using post-I as reduced intensity conditioning GVHD prophylactic options going forwards in patients who are well matched. There are ongoing studies to look for suitable biomarkers, and those will be coming out over the next few months. Dr. Zaidan, who's one of our leaders in the leukemia program, asked me to condense some of the TCT slides with the ASH hematology slides, because those are really practice changing. Here I'm presenting a study that's called the Sierra study. Dr. Seropian was the principal investigator on site for this. This was a multi-center pivotal phase 3 study of IMAP, which is a drug I'm going to talk to you about prior to allogeneic stem cell transplant, versus conventional care in older patients with acute relapsed refractory leukemia. Remember, the majority of the patients actually don't get to transplant. Look at the median age for these patients that develop acute leukemia is somewhere around late 60s, early 70s, and they're transplant ineligible. So in that patient population, while we've had multiple new drug developments, transplant is historically considered not suitable. So into that domain, this trial is trying to now make headways with some interesting results, as I'm going to show to you all here. As I was mentioning, relapsed refractory AML generally has got poor prognosis. On top of that, if you add older age, it makes it complicated. There are several reasons for that. Historically, we've always believed intensive induction is necessary to keep remission going for long term, but most of these patients are not able to tolerate it. And even if they tolerate it, the toxicities are higher if you continue to long terms, and that leads to substantial treatment-related mortality. Now, since transplant is a higher intensity of treatment compared to the non-transplant option, the TRM tends to go up in the population. However, we are able to get some of those patients who have relapsed refractory phenotype back into remission. And one of the conventions that we tend to follow in relapsed refractory AML is we tend not to transplant those patients in active disease, because back maybe prior to 2000, when we used to do relapsed refractory AML, who had active disease when we didn't have these novel drugs, the risk of relapse was pretty high and the TRM was high. So based on that, there are multiple novel drug development strategies that have come on. But what IMAP is now trying to do is trying to address the question slightly differently. So first of all, what is IMAP? IMAP is basically a combination of things. They have a CD45 antibody that's conjugated to radioactive iodine, and it is designed to deliver targeted myeloablative radiation dose to the hematopoietic cells and immune cells, and then supplemented with reduced intensity conditioning prior to an allogeneic stem cell transplant. Remember, good old days when we used to do allotransplant, we used to use radiation-based regimens. TBI kind of, while is useful to suppress your immune system, eradicate leukemia in the marrow, it can cause significant organ toxicity because it's a total body radiation. Here, they're trying to develop targeted radiation to leukemia cells, bone marrow stem cells, to address the primary problem of acute myeloid leukemia. With induction and conditioning, the hope here is that usage of this drug would allow rapid access to bone marrow transplant for multiple patients who have relapsed refractory phenotype. So this was a prospective randomized study, which is a phase 3 study exclusively for patient populations greater than 55 to compare rates of durable complete remissions that would last greater than 180 days following initial complete remission between the two arms. So the study was randomized for IMAP followed by transplant versus physician's choice of conventional care followed by transplant. And physician's choice of conventional care included more than 20 different drugs that reflect contemporary practice, including the BCL2 inhibitors, FLT3 inhibitors, etc. Here's how the study design goes. People have relapsed refractory phenotype greater than 55, randomized 1:1, IMAP to conventional care. Then look for whether they have CR or not, and if it's a CR, what's the duration of CR, whether they last 6 months or not, and that's the pre-specified primary endpoint, lasting greater than 180 days. Whereas with the conventional care arm, it depends whether they get into CR or no CR. If they're the CR, then they could go to the standard of care transplant or standard of care physician's choice. This concept of drug delivery needs hospitalization slightly earlier than what we would normally do in the context of a bone marrow transplant. So those patients were admitted around day 19 to get a test dose of radioactive iodine, and then they have to be kept in the hospital for a few days until the body eliminates all the radioactive doses. Then the data is then sent across to develop a therapeutic dose of the IMAP, which is then given around day -12. You wait for about 8 days for that to take effect. Remember, these are people who have active blast and active disease coming into this. This drug would ablate most of those patients. And then you go on use the principles of transplant, which is to use low dose of immunoablation with fludarabine and TBI, which lymphodepletes and also eradicates some of the disease, followed by hematopoietic stem cell rescue. And the option of GVHD prophylaxis is tacrolimus or cyclosporin with mycophenolate. Here's the concept. Now, equal number of patients randomized to IMAP and conventional care, 76, 77. 66 patients received therapeutic dose. 66 were able to get a transplant. Per protocol analysis, 59 were eligible. In contrast, the number of people in the conventional care that were able to get to CR was 14. Not able to get to CR was 62. For those who got to CR, about 14 of them, all 14 were able to go to transplant. Those who did not get to CR, of 62, 18 did not receive any further care, likely went on to receive what we call palliative care options or for the treatment, crossed over to IMAP. The crossover was allowed for people who did not reach CR after having been in the conventional care arm. About 44 crossed over to IMAP. Of those 44, 40 did get to allogeneic stem cell transplant, and 38 were eligible for protocol analysis. In the interest of time, I'm going to run through this fast. The median age was about in the mid-60s. We had favorable, intermediate, and adverse risk. It included primary induction failure, early relapse, refractory, second plus relapse. And I mentioned that with an emphasis because those of you familiar with the ASAP trial did not include later relapses and only which had earlier relapses. All of them had about 3 lines of median therapies. People had already exhausted targeted therapies. About 60% of the patient actually had a KPS score, a performance score less than 90%, and the marrow percentage and the marrow blast percentage was around 30% and 28%, which is significantly high, truly reflecting active disease population. And here are the doses that have been presented, whether you got IMAP or crossover. Doses of the marrow was about 16 gray here, whether you got it as IMAP or the crossover. Time to HCT from the randomization was 29 days. With the standard of care arm, the median time was 66 days. In the crossover arm, the median days was 61 days. Engraftment was very good. The median time was 14 days, which is what we normally see with our standard transplant, somewhere around there. For platelet was about 19 days. With the standard HCT, the kind of matching up nicely. And the comorbidity index, as I was showing here, approximately 50-50. When you look at durable CRs, here's the number. About 22% of the patients in the IMAB arm had durable CR on the study endpoint versus none in the conventional care arm. In the crossover arm, 91% received transplant, with 52% of those achieving CR or CRI. Post-HCT maintenance with the TKI was only allowed for IMAB patients with 3 mutations or those who are BCR-able translocations at screening. And these are the survival curves. The overall survival was doubled with the IMAB arm. It was 6.4 months compared to 3.2 months. 1-year survival was almost doubled, 26 months versus 13 months. And again, the median overall survival in the crossover cohort, as shown in the blue line, was about 7.1 months, and the survival there was about 35.8%. Forest plots essentially showing hazard ratios was applicable across most groups, except the KPS of 90 to 100. And the relapsed refractory, those are the ones where they cross the line. And when you look at event-free survival in intent to treat group, IMAB had a better result, 28% versus 0.2%. Specifically, when you follow these patients for long-term survival, 6-month survival was 100%, 12 months 92%, 18 months 71%. At 2 years, almost 60% of the patients that had remission were alive and ongoing. Here are some of the adverse events. As you can see here, we would anticipate a high dose of chemotherapy might cause problems. Neutropenia was on similar rates both sides. The mucositis was almost similar on both sides. The rates of GVHD was not really different, but sepsis was lower in the IMAB arm compared to the conventional arm. So in summary, in patients greater than 55 years with active disease, IMAB followed immediately by a reduced intensity transplant. In is population that's typically not transplant eligible is now made feasible and possible as a result of the study. IMAB in general was well tolerated and resulted in engraftment in all those patients and had a high rate of durable CR lasting greater than 6 months. And for those who have CR lasting more than 6 months, about 60% were alive on the long run. The rates of serious adverse events were small. IMAB offers a very novel solution to increase access to transplant and improve outcomes in patients that are relapsed and refractory. I have 2 more slides, and I'm going to wind up with that. Some of you who were at ASH probably have heard of this trial, ASAP trial, which is kind of trying to gain access for allogeneic transplant for those who have primary induction failure, trying to make a case saying that the need for further intensification chemotherapy to achieve CR is perhaps not needed, as long as you can sequentially give chemotherapy and take them to transplant if you have a donor available. Thereby, they're kind of trying to show that you probably don't need to achieve a CR if you have a donor availability. But some of the practices in that study might not be applicable in the United States. But for the purposes of discussion, I've left it here. But I would end my talk by summarizing this for those of you who are interested, since IMAB and ASAP are now trying to advance transplant in the context of relapsed refractory study. Let's see what they both talked about. ASAP trial was predominantly looking into fit early relapse patients that was primary induction failure or first relapse. It uses intensive sequential conditioning, chemotherapy rather, followed by transplant preparation regimen, which is Flumel, TBI, and an 8-way. The flip side to that is none of the novel therapies that we use to treat relapsed refractory leukemia was allowed. So you can argue maybe that's not suitable for practicing in the United States. And even then, when we have known in the past that we use repeated chemotherapy for relapsed refractory disease to make them get into CR to get to transplant, perhaps that's only about 15 to 20% of the patients. We think that might impact even if you decide to give a sequential therapy, maybe about 700 to 1,000 patients, as Sergio Gerald summarized it beautifully, and may be eligible to become transplant using that intensive chemo approach. In contrast, Sierra included fit or unfit patients, both with primary induction failure or first relapse, who have traditionally been considered transplant ineligible, and also included second or later relapse, widely encompassing extensively relapsed cases, including those who are relapsed with contemporary available medications that most people might have gone into palliative care, are now getting eligible to consider allogeneic stem cell transplant. And I think, as Dr. Gerard mentioned, he thinks with this concept, approximately 8,000 patients who were historically considered not transplant eligible may be eligible for allotransplant if we have a donor ready and be available. And I foresee this drug being explored for different donors, conditioning regimen, both hematologic, both neoplastic and non-neoplastic conditions going forwards. With that, I'm going to end this, and thank you all for your attention. I'll open up the platform for wider questions. Thank you so much. You muted, Stuart.
Sorry. Thanks, Lohith. So we have just a few minutes to field some questions. If people want to submit, I'll just start with a quick one that came through the chat that we couldn't respond to, and this is for Dr. Isufi. Can you just comment on the use of corticosteroids in CAR T patients? Are these allowed? Do they impact therapy? I'm paraphrasing the question, but the question was really, what is the impact of using steroids in these patients?
Yeah, so we generally try to limit the use of steroids before CAR T collection. It's critical that they have at least a 1 week window before CAR T. We do know that steroids are very lymphodepleting. In the early post-CAR T period, when they develop toxicity, though, it has been shown that giving a short course of either steroids or other antibodies like tocilizumab to treat cytokine release syndrome or neurologic toxicity does not impact the long-term outcome of these patients. But again, the steroid tapers are rather quick, typically less than a week.
Okay, thanks. And I see one other question in the chat from Dr. Zaiden, and this regards the whole issue of remission status prior to transplant, and asking if in the IOMAB study, was there a need to document CR before the transplant? So the short answer is no. IOMAB was part of the transplant conditioning. So these are people who had relapsed refractory disease, had bone marrows with an average of 30% blasts, who instead of our paradigm of going to salvage therapy and requiring remission, that was the control arm, they just went right to the transplant. So they got the therapeutic dose in the 12 days before the transplant, and that's ablative. So there's no doing a bone marrow to look. You saw the average delivery of radiation there was 16 gray. That's about 3 to 4 gray higher total body radiation dose that we can safely give any patient. So this is a very ablative dose of radiotherapy. And marrows are not done prior to delivering the transplant. You have to rescue the patient with the graft. And the high CR rate confirms the efficacy of that agent.
I think Amr suggested CR.
So Amr is asking about requiring CR in one arm and not the other. So the other arm was to choose conventional treatment. You're right, and then those patients don't go to transplant. Remember, this is a group restricted to age 55, and we don't have, if you're referring to the ASAP study, we don't have FLAMSA regimen, which is a popular German regimen. And if one looks over 40 years of evaluations of outcome for allografting, the single most predictive variable for treatment failure is disease status. It's an increase in blasts in the marrow pre-transplant. So remember, these were people with these weren't people with just 6% blasts in their marrow. So they were allowed to cross over. But these are people who conventionally don't go to transplant around the world, really, unless they're on a clinical trial like that German study. So,
there's actually an excellent review by Zaidan Amr and Dan Polia about even the need for CR after induction therapy. I'm sure Amr can extrapolate that into relapsed refractory setting. How CR even came into the forefront, whether it's of essence. I'll refer him back to his own publication with that, which tells you the real utility of CR in modern times.
Yeah, probably a good subject for further discussion in our transplant leukemia meetings. Let's see.
Stuart, I also just wanted to say that this type of therapy is also very exciting for other forms of adoptive cell therapy, because I know that they are looking at giving non-myeloablative doses of this type of radioimmunotherapy, actually at lower doses rather than ablative for patients pre-adoptive cell therapy. And we already have data on how radiation might actually decrease Treg populations, for example, and that may be actually important in the post-CAR T setting as well.
One last question for Dr. Isufi in the Q&A. How to choose between CAR T-cell therapy or immunotherapy? Very, very appropriate question, not just for lymphoma, but Iris, what do you think?
Yeah, so I mean, I think that's a very valid question. Unfortunately, immunotherapy in terms of PD-1, PD-L1 axis has not had very good outcomes in the setting of non-Hodgkin lymphoma, particularly aggressive lymphoma. And so, that those particular drugs have very low CR rates as single agents, and they do not add much to combinations. So I think a CAR T would be preferred. In terms of antibody drug conjugates, I mean, I think that's a whole other class of drugs that is competing with CAR T cell therapy in all fronts, including non-Hodgkin lymphoma, ALL, and multiple myeloma. And I think we have to look at the targets to make sure that when we give these therapies, the patients retain the target, and how to sequence them is actually a matter of very hot debate and ongoing trials right now, what the best approach might be with these bispecifics. I know there was another question in the Q&A, for example, for leukemia in patients who, for example, received blinatumomab pre-CAR T. How do those patients fare? And that because both of those are CD19 targeting therapies, and so sequencing is very important there. And the interpretation of the data so far is that if they have a good response to blinatumomab and they maintain their CD19 status pre-CAR Ts, that they do well. However, if they do not have a good response to blinatumomab, they will also respond poorly to CAR T. Unfortunately, that's a high risk group. And if they lose CD19 after blina, then they actually have very poor responses to CAR T. So we have to be careful about how we sequence these therapies, and we have to really monitor. I mean, I know many academic centers now, when they look at CD19 and CD22, they do not just report, for example, whether it's DIM positive, or they will actually report a number for the level of expression, and that becomes very important in terms of, I know that's what the NCI does, and that becomes very important in terms of what the next therapy that they use is going to be.
If I can add to that comment, that the nature of drug development was such that we had to go with ENA, blina, and then CAR T. CAR T, despite having heavily treated population, had highest CR and MRD negativity rates. So that kind of tells you that it's a potent drug, just that we may not be able to get it in time, whereas other drugs we may be dispensing it off the shelf. In terms of the potency, it's clearly there, despite a heavily treated population. The rates of CR compared to inotuzumab, blinatumomab, and the MRD negativity rate is something that we need to look into it, if we're really looking into that.
Okay, I think we're out of time. Thanks, Dr. Isufi and Dr. Gowden. Thanks for all the good questions. Hope everybody has a good weekend.
Thank you.